Hi everyone, this is Tim, your Block 3 lecture instructor, and this PowerPoint voiceover is on DKA and HHS. So DKA is a diabetic ketoacidosis, and HHS is hyperosmolar hyperglycemic state. Um, this is all based on your patients or having blood sugars that are extremely high. It's also based on, for specifically DKA, your patients having ketones in their bloodstream, and which HHNS is pretty much the same as DKA, but HHS is actually for type 2 diabetic patients. Those patients actually have the ability to produce and use insulin, just not efficiently, whereas DKA is actually a type 1 diabetic problem, and it's because of the fact that they do not produce any insulin, and because of that, their byproduct is actually ketones. So a little, I guess tidbit is really that DKA is type 1. Ketones are in the urine, and we actually have to be able to fix them, and it's going to be some sort of intervention from us that's going to actually fix them, not them staying at home, and there's not much they really can do. And we'll definitely go over this in lecture and answer a lot of questions. This does get a little confusing. I'm going to try to keep it as easy as possible, or as at least as simple as possible, so kind of bear with me. So DKA, again, you have a patient who's type 1 diabetic. For whatever reason, they're sick, their blood sugar goes up, and in order for their body to try to fix that based on homeostasis, their body breaks down fat in order to get some energy, and because of that, the byproduct of that fat breakdown is ketones. And again, this is all based on homeostasis. The body's trying to fix itself. Unfortunately, it doesn't realize that what it's trying to do isn't working. So again, the patient will get sick, their blood sugars will go up, their ketones will increase, and they'll try to do what they possibly can, whether them taking more insulin in order to fix it, whether them drinking more water. They'll try to do whatever they can at home in order to get this lower. It just doesn't work. So the patients that come to you, whether it's in the emergency room or whether they come to you from the emergency room to the floor, is all about us doing interventions to actually fix them. So what causes DKA? Go back to your Block 2 lectures and looking at your type 1 diabetics. Your type 1 diabetics, remember your sick day rules. Remember that, there's several reasons why their blood sugars could go up, and them actually having problems. I put in here specifically that maybe there's not enough insulin. Maybe they didn't inject enough insulin for what their actual body needed. They wake up in the morning, their blood sugar is, let's say, 300 for whatever reason, and they decide to give themselves a couple units that brings them down to 250. It's not enough. Again, their body's going to try to fix that problem. It just doesn't work. So again, when they text the blood sugar again at noon, maybe it's 250. They may give themselves a couple more units. It may bring them down to maybe, let's say, 225. Again, it's not enough to be able to bring their blood sugars down to 100, which is where we're supposed to be roughly. And because of that, their body starts to break down fat, and that breakdown is what actually causes the ketones to be released. Maybe there's not enough food. When patients are sick, they're not eating, they're not drinking, they're not doing the things they need to because they don't feel well. Infection, not eating well, those will cause blood sugars to go up. And because of that, they're not actually doing anything to be able to make their blood sugars come back down. Insulin reactions, you've all have studied in Block 2 the dawn phenomenon. Your patient takes their insulin in the middle of the night. They wake up first thing in the morning. Maybe their blood sugar is actually either extremely too low and they need more sugar, so their body will actually break down fat in order to get that energy, and because of that, the ketones will come. Or maybe it just wasn't working well enough and they were actually getting a reaction from the insulin itself. So symptoms, again, we're going back to block 2 stuff: polyuria, polydipsia, polyphagia. So when your patient's blood sugars are too high, you get those 3 Ps. Because of that, your body is trying to actually compensate and trying to flush out those ketones, trying to flush out that high blood sugar. It's trying to fix itself, and it just can't. So for symptoms, you're going to have thirst, very dry mouth. You're going to have frequent urination because, again, they're trying to actually get rid of the sugar. Constantly feeling tired. You have dry or flushed skin because at this point they're now starting to get dehydrated because their body is trying to get rid of the sugar and it's actually urinating too much. You're going to have the nausea, vomiting, and abdominal pain. And this is probably either a combination of toxins building up or, again, their body's trying to get rid of the sugar and the ketones. So, it's trying to expel this from any orifice that they possibly can. Nausea may be one of the reasons. Unfortunately, it's a vicious cycle of your patient has high blood sugar, high ketones. It's trying to actually maintain homeostasis by urinating or maybe even vomiting. Unfortunately, that makes your patient dehydrated, which then makes your patient's blood sugar go higher. It's just that cycle of if it's trying to get rid of it, but it's getting rid of it in the wrong direction. May have difficulty breathing, and this is because of the acidosis from the ketones. The fruity odor of the breath, same thing. Again, they're doing Kussmaul's breathing in order to actually blow off all that CO2. They may actually have a hard time paying attention or having some sort of confusion. Again, this is either a dehydration issue to where they've actually either vomiting or urinated too much and they're low on electrolytes and hydration, or it's actually a ketone problem as far as, or maybe it's because of the fact that their blood sugar is way too high. Diagnostic testings, see here, when you're ill, when you have cold or flu, check for ketones every 4 to 6 hours. So your patient comes to you through the emergency room or through the emergency room to you on the med-surg floor. What they're going to do is they're actually going to test for ketones, and they're actually going to test their blood sugars. If the ketones are present, they actually have DKA. And they're also going to check their blood sugar to find out how high are they really. They're going to check it every 4 to 6 hours. Anything more than 250 or 240 is actually a problem. Again, they're going to check for blood sugars, and they're going to actually look for the ketones in the urine. Electrolytes. This will vary according to decrease or degree of hydration. It also have an increase in binding creatinine and hematocrit. I want you to think about as far as interventions in a sense that we're going to do things based on how we're trying to fix the patient. So if your patient is dehydrated, we're going to give them fluids in order to get them hydrated. A lot of times if you hydrate your patients, labs will actually come down. An increase in binding creatinine and hematocrit, that might be more of a dehydration and a concentration issue. So if you actually give them enough hydration, the binding creatinine and the hematocrit actually may normalize and become less concentrated. So they may not be as high as we thought that they really were. So hydrate them first. Again, they're also going to come to you dehydrated because of the fact that they're urinating way too much trying to get the sugar out, and they may also be vomiting way too much in order to get the sugar out. So that dehydration issue is really going to be probably either step number 1 or problem number 1. So if we can fix those things, we might start fixing other problems at the same time. Again, you're checking blood sugars, and you're also checking the ketones in the urine. So I threw this in here just so that way you all had an idea why I keep throwing in the sick day rule. So, your patient is at home and they're sick, whether it's the flu, whether it's the common cold, whether they don't, for whatever reason, they don't feel well. And they're not consuming either enough fluids or enough foods in order to keep their energy and to keep their hydration levels high. They're going to check their blood glucose level every 2 to 3 hours, maybe even more based on what's going on. So, and the reason why they check it every 2 to 3 hours is that they want to see if they're slowly going up and if they actually can try to take care of that. Checking your blood sugar at 8 in the morning and wait until noon when you normally do it might be too late. So check it more frequently to see if there's actually a trend of it going up. For insulin, they're always going to continue taking their insulin even if they are sick to avoid that DKA. Again, if their blood sugar goes up and they're not taking insulin to bring the blood sugar back down, their body's going to start breaking down fat in order to get the energy, and because of that, the byproduct is the ketones, and that's what starts this whole slope. Carbs, make sure you take enough carbs and drink enough fluids. If your glucose level is high, stick with sugar-free drinks, and if your glucose is low, then drink carb-containing drinks. So again, I know that your patient's sick. I know they're nauseous and vomiting. I know they don't feel well, but if they can at least consume some sort of carbs, which is then going to give them some energy, then their body won't break down fat to do that, and that's not going to, that will actually keep them from getting the ketones. So whether it's sugar-free drinks in order to keep themselves hydrated, but not necessarily make their blood sugars go up, or whether it's actually consuming something with sugar in order to maintain what they have, it's going to, try to keep them as less ill as they possibly can. And for ketones, check the blood and the urine for ketone levels every 4 hours. Take rapid-acting insulin if ketones are present. Again, this is going to be blood sugars are, 200, 150, 250, 300. They're going to be very high. They're wanting to take something fast-acting so it starts to bring them down. Patients who are on regular insulins or are NPH, that doesn't act fast enough, and it's going to take a while for it to work. Because it takes a while, they may be getting sicker as they're waiting for that insulin to actually work. Remember to drink plenty of fluids. You want to try to flush out the system, trying to actually keep themselves hydrated and try to make themselves as well as possible. All right, so this is where it comes to a kind of a step-by-step process, but again, we're looking at the patient first. This is very, very gray, so do not memorize step 1, I'm going to do this, step 2, I'm going to do this, step 3, I'm going to do this. I want you to start remembering what interventions you'll do, but you're going to do them at the time that your patients actually need them. So interventions, you're going to maintain their actual fluid balance. Patient comes in, blood pressure is low, heart rate's high. You know that they're dehydration, they're going through some sort of hypotension or hypotensive shock because of the fact that their body was trying to maintain homeostasis. They urinated way too much, trying to get the sugar low. They may have been vomiting all night because of the fact that they have the flu and just wasn't feeling well. They're dehydrated. You're going to actually give them normal saline, 1 liter, maybe even 2 liters, 3 liters, it doesn't matter. You're going to give them normal saline and give them liters over liters over liters based on trying to hydrate them as much as you possibly can. But you're going to go back to block 1 and block 2 stuff. You're going to check blood pressures frequently. You're going to make sure that you're not going from, dehydration to all of a sudden giving them 1 or 2 liters and their blood pressure now is, 200 over 109. You want to do their vitals to make sure that what is going in is working, but it's not working to an extreme that you went from a simple let's hydrate them to now we've overly hydrated them and now we have another problem we have to fix. After you've actually hydrated them, you're going to then give them half normal saline with 20 of K. This is actually half normal saline with potassium added to the actual bag. You're doing this because of the fact that you're now wanting to, the normal saline was to hydrate the vascular system. The half normal saline was actually to hydrate the actual cell. With that, their potassium will actually start to drop. They add the potassium to the bag so that way you can actually, even though we're dropping their potassium, we're giving them potassium in order to equal those things both out. You're also still checking their blood sugar. You're making sure that they're not dropping too fast. You're making sure that they're actually not going to go too high. You're also still going to do vitals, making sure that everything kind of stays the way they're wanting to do it. Once they actually hit about 250, you're going to start giving them D5 half normal saline. This D5 is actually sugar water. You're doing that and it sounds stupid. Like, why would you give sugar water to somebody who's diabetic? But you're doing it because you don't want to drop them too fast. You never want to drop a patient from, let's say, 1,000 down to 250. It puts their body into shock. Their body doesn't know what to do with it. It just really affects their system. So again, you're going to hydrate them. Vascular system wise, get their blood pressure back up, you're going to get their heart rate back down, you're then going to switch them off to half normal saline with 20 of K in order to actually hydrate that cell. Again, they're going to watch the potassium levels to make sure that you're not actually losing too much potassium. You're also going to check it to make sure you're not giving them too much potassium. You're also checking their blood sugars frequently to make sure that they're actually coming down slowly but not too slow, but you're also making sure that they're actually not going to go too high, or that you're not doing anything to actually fix it. So the electrolyte balances, it's the potassium. The potassium is going to fluctuate up and down, and you want to make sure that you know whether it's fluctuating too high or too low. I want to throw this in there. You may want to throw your patient on a heart monitor because of the fact that if you're giving a lot of medications that either may decrease the potassium level, we know the potassium levels are 3.5 to 5.0. You may increase their potassium level. Let's say it's 5.5 or 6. Putting them on a heart monitor may show you early on some sort of dysrhythmic problems. We're also going to, at some point, start giving them an insulin drip. That insulin drip is going to push potassium back into the cell, and because of that, it's actually going to decrease their potassium level. So putting them on a heart monitor is going to tell you externally if they're having some sort of dysrhythmic problem now because of a hypokalemic problem. So IV insulin, you're going to give them an insulin drip, and it's going to be regular. And the reason why it's regular is because of the fact that you want to bring them down slowly, but you also want to be able to regulate it. Giving fast-acting insulin is going to work way too fast, and it's going to be too hard on the actual system. So regular insulin is more of a slow but steady trending down. Rapid's too fast, and anything else is too slow. Let's see here. So IV insulin, you're going to do that in order to bring them down. You're going to give them normal saline for hydration because of the fact that you're going to not only try to hydrate them and replace what they've been losing through their urination and possibly through their vomiting. You're also going to watch their potassium levels. You want to make sure that their potassium level stays about 3.3 or above. So you do know that 3.5 to 5.0 is a normal range, but again, you now have a patient with a problem that may actually fluctuate that potassium. So I don't necessarily want you to think, oh, well, okay, it's no big deal, we don't care. But the 3.5, 3.4, 3.3s, that's where we expect them to be. So we're not necessarily not worried, but we're not extremely upset by the fact that it's actually coming down because we know that was going to happen. Check blood sugars every hour and the potassium levels every 6. And the reason why we do this is because of the fact that if you're putting them on a regular insulin drip, and we know that it's going to work, we want to check hourly to find out if it's working too much or if it's not working enough, and be able to act accordingly. Waiting hours for whether or not it's working or not, we don't want to walk in 3 hours later and find out that the several units we gave them per hour is working way too much, and now we actually have to fix another problem. We also don't want to not check them and find out 4 hours later there was not enough, and they went from 500 up to 1,000 because it just wasn't enough. Potassium levels, you're checking them every 6 hours because you want to find out if they're trending up or down. Have them on a heart monitor to find out maybe something might actually tell you a little sooner than that. But again, we also know the potassium level is going to come down because of the insulin drip. You're also going to look at acidosis management, and again, this may actually resolve itself once you start bringing the blood sugar down. Once you start hydrating them, they may go from being acidotic to alkalic, or at least having some sort of normal pH level. So the Kussmaul's breathing may actually subside, the nausea and vomiting may actually subside, the constant urination may subside because you're now doing interventions to fix that DKA and that high blood sugar. Assessment-wise, again, put them on a heart monitor. You're going to check for dysrhythmias. You're also going to do labs. You're checking for potassium, whether it's going down or going up. You're also looking at sodium levels. And this is because of the fact that whether you're giving them normal saline, D5 normal saline with 20 of K, or whether you're doing something else, you want to make sure that either you're not dropping them or you're not diluting it too much. Definitely doing vital signs more frequently. You're looking for blood pressure, whether it's too high because there's too much hydration, or whether it's too low because of the fact that the interventions you're doing are not working and they're still constantly urinating. And the heart rate will actually tell you a lot. If it's going up, it may be trying to compensate. If it's going down, there might be some other issue, whether it's a potassium issue or whether or not it's a dehydration issue that now has gone to an extreme and your heart rate is now actually super low. You're going to look at ABGs to find out as far as the acidosis or the alkalosis. You're also looking at CO2. You're also going to check for breath sounds and assessment for that. You're doing neurochecks. Are they alert and oriented? Are they still pretty lethargic, or have they gone to an extreme where they're actually not responsive at all? You're also looking at blood glucose. Again, you're looking at this every hour to make sure that what you're doing is not too much or not enough. And you're also looking at eyes and nose. If you just gave your patient a complete liter of fluid within an hour and all of a sudden they have not urinated, it might be because of the fact that you're now hydrating them and you're now trying to fix that problem. So a lack of urination kind of is a normal response because of the fact that you're now fixing a lot of problems and you're now trying to hydrate them. But what if whatever is going in is actually coming out, you're not really doing anything. So you need to kind of keep fixing those problems. Evaluation-wise, once the patient's blood glucose is below 250, their potassium level is within normal limits, and they can actually tolerate a diet, now you can actually switch them off of the actual IV insulin and put them on sub-Qs. This is actually really important. If your patient isn't eating and we didn't fix the actual problem that was causing them to be sick in the first place, then we need to continue doing what we were doing in the first place. Hydrating them, insulin drip, checking their blood sugars, giving them potassiums. There's a lot of stuff that we need to continue doing as far as interventions to fix their DKA problem. But if your patient isn't eating, you didn't do anything. Diabetes mellitus is controlled with sub-Q instead of IV, so we talked about that. Education, again, this is not a non-compliant patient. Your patient with a type 1 diabetes who's 25, 30 years old, they've lived this long with their type 1 diabetes. They probably, for the most part, have lived their entire life insulin dependent, being compliant, making sure that they eat well, making sure that they take their insulin when they're supposed to. They probably have gone through, most of their life trying to figure out what insulin works the best, and making sure that they stayed as healthy as possible. This is that patient who is probably sick, something was going on, and it got away from them, and they actually had to come to us in order for us to fix it. So, and I say this because of the fact that we get too wrapped up in the whole non-compliant diabetic patient of, well, if you took your insulin, you wouldn't have been here, but that's not really the case. This is a patient who is sick. They stayed home. They tried to do what they could to try to stay out of the hospital. They probably followed the sick day rules. They probably actually took their insulin. They probably tried to drink as much as they possibly could based on how well or how bad that they actually felt. They were trying to keep themselves out of the hospital, which was the inevitable, and that's where they are. But you may have some patients who actually are newly diabetic, or maybe they actually didn't know that they were diabetic until they came to the hospital not feeling well, and now we actually have to start with a lot of education. Do not bombard them with everything you know about diabetes and trying to fix them. You need to actually be able to take it step by step, try to give them little information at a time so that way they can absorb what you're telling them and it doesn't become too overwhelming. And then they can actually be discharged home. Now, as far as with HHS, hyperosmolar hypoglycemic state, again, this is actually the same patient but being a type 2 diabetic instead of a type 1 diabetic. Again, they're sick. They took their metformin, which is for their type 2 diabetes. For whatever reason, it wasn't enough, and they just went down that slippery slope of the same thing. They're sick. They're nauseous, they're vomiting, they're urinating way too much, they're going through the 3 Ps, they're going through all those things. They it just wasn't doing enough. So they actually came to us because of the fact that they're way too sick. And now, again, they're dehydrated. Their potassium and sodium levels are either too high or too low based on what they've actually lost. And they actually came to us to try to figure all that stuff out and try to fix it. Again, their blood pressures or blood sugars are way too high, and we're actually having to fix them. So again, the DKA patient is that type 1 diabetic with ketones, and the type 2 diabetic without ketones, because of the fact that they do produce some insulin, it's just not enough. That's what puts them in HHS. All right, so now we have hypoglycemia. So again, this is really just, the patient, whether it's type 1 or type 2 diabetics, they don't have enough blood sugar itself. So whether it's the metformin was too much for the type 2 diabetic, and it went from a normal 100 and something down to a 50 or 60, or it was your type 1 diabetic who actually took their insulin this morning because their blood sugar was 250, and next thing you know, they went to the gym and ran about 10 miles and found themselves to go from a normal limit down to like 50 or 60. So again, at this point, they're they're coming to us, or the hypoglycemic state is the fact that it's 50 or 60, and they actually need more sugar in order to bring them back up to the 100. So just a couple sentences here. So abnormal low blood glucose level below 50 or 60, too much insulin or oral hypoglycemic agents which brought their blood sugar way too fast, way too far down, excessive physical activity or not enough food. They could be sweating, tremors, tachycardic palpitations, nervousness, and hunger. For the central nervous system symptoms, it's an inability to concentrate, having a headache, confusion, memory lapses, slurred speech, or drowsiness. Basically, they just don't have enough sugar in their body to sustain life. Severe hypoglycemia is disorientation, seizures, and loss of consciousness, and possibly death. So here's a lot of points as far as about the hypoglycemia. So patients with underlying renal dysfunction, congestive heart failure, or both are increased risk. And this is basically due to the underlying renal dysfunction is maybe they're actually urinating or producing urinating or way too much and losing all of their fluids, which is causing them to be dehydrated, which will actually cause their blood sugars to go low. It could be congestive heart failure or CHF. We're giving Lasix or diuretics to patients that are CHF because we want the fluid off. But the more they urinate, the more the sugar may be following, and they're actually starting to lose that, so it'll make them hypoglycemic. Drugs that are raise serum glucose levels, inhibit insulin absorption. Let's see here. Alcohol and cocaine. Drugs and alcohol are big issues for diabetics, whether type 1 or type 2. It will cause problems. Let's see here. Talked about the diuretics, beta blockers. So just keep in mind that there's a lot of reasons why your patients may either go up or down. All right, so let's see here. As mentioned above, the elderly, the chronically ill, and the institutionalized populations are increased risk for HHS. Any living situation or comorbidity that prevent adequate hydration, including, for example, immobility, advanced age, disability, dementia, agitation, impaired thirst response, restricted water access, or restraint use. So the reason why I threw this in here is because I've worked med-surg for many years, and you walk into grandma's room and she's 90 years old and she's confused, and breakfast tray comes up and she's eating breakfast, doesn't really feel like eating too much, takes a couple bites and she's really just done. The aide comes, takes the tray away, and next thing you know, we realize that she ate 25% of her meal. That's fine, that's normal, but we don't stop and think, okay, so when's the last time we actually offered grandma water? Here, drink some water, keep yourself hydrated. Or if grandma comes in with a UTI, and we know that the UTIs are going to cause her to urinate frequently, trying to get rid of that infection, now she's being dehydrated. We put her on normal saline. Yes, she's getting the drip and it's working. We're putting her on antibiotics, but she's still frequently urinating. We're putting in hydration, but it's also coming out because of the infection. But we don't really stop and think, grandma doesn't have the thirst factor as we do. So we're not offering her to drink more water more frequently. So I threw this in here because I want you to kind of, keep in mind that your elderly patients, your confused chronic confused patients, people that are restrained because of the fact that they're crazy and need to be strapped to the bed. We need to keep offering them hydration, keep offering them things to drink, trying to keep them as hydrated as much as possible, and we forget about that stuff. So I threw that in there because of that. All right, so let's see here. Symptoms: increased thirst and urination, feeling weak, nausea, weight loss, dry mouth, dry tongue, fever, seizures, confusion, coma. Again, these are all really just dehydrated patients, and this is either based on the fact that they're urinating too much, whether it's their blood sugar is too high, or maybe the fact that their blood sugar is too low. So you're really kind of, the whole point of this entire PowerPoint voiceover was really just to explain to you that look at your patients, look at what they're going through, and try to figure out what you can do to actually fix it, and try to get them as well as possible. Let's see here. Assessment and diagnostics. We got extreme dehydration, fever higher than 100, increased heart rate, low systolic blood pressure, and eyes nose. So again, your patients getting dehydrated because of the fact that they're urinating way too much. They have a fever, whether it's because of the fact that they are dehydrated, which will cause them to have fever, or maybe there's infection. The increased heart rate is because of the fact that with extreme dehydration comes a low blood pressure, and the increased heart rate is to be able to compensate for that. Eyes and nose, again, you're looking at what goes in is actually coming out. If what goes in is coming out the exact same, they're not retaining any of that stuff. You're also looking at labs as far as blood osmolality. You're looking at blood creatinine. Is it high because they're dehydrated? Is it high because there's a kidney issue? Or is it low because either we've hydrated them way too much, or is it low because of the fact that what is going in is urinated out as fast as it possibly can? You're looking at blood sodium levels as far as whether or not it's high or low based on the excessive urination. Ketone test, again, if they're positive for ketones, type 1 diabetic, they're going through DKA. Looking at blood glucose, is it too high, too low? Evaluation for possible causes maybe include blood cultures. Again, if grandma comes in with a UTI and has type 2 diabetes, it would be standard reason that one, she's urinating too much to be able to get the UTI fixed. But in the same sense too, she's also HHS, which means that she's going to concentrate her blood levels, which is going to throw her into some sort of high glucose level. Do a chest x-ray. Maybe grandma's got pneumonia, which is a source of infection, which causes her blood glucose to go up. You're also going to do EKG, making sure potassium levels are within normal limits, and you're also doing a urinalysis, and also probably doing some sort of culture to find out what is going to fix that infection. Interventions, again, you're doing fluids. This will improve blood pressure, urine output, and blood sugars. You're also looking at potassium and sodium levels, and you're also going to replace them as needed. So if grandma is at a 3.4 or 3.3 or even a 3.0, you might either have to give her some potassium tablets in order to bring that back up, increase her diet, and increase the amount of potassium in her diet, increase her sodium levels by adding salt to her foods, maybe give her some normal saline, maybe give her some salt tablets. And then again, grandma, even though she's a type 2 diabetic with high glucose levels, may actually need some insulin in order to help with that. Again, insulin pushes potassium back into the cells, so the more insulin you give her, the more potassium, lower her potassium level may be. So again, if grandma has a potassium level of, let's say, 5.5, which is high, giving her a little bit of insulin will actually decrease her blood sugar, but it also will decrease that potassium level. So that's one way of doing that. So again, you're always constantly looking at, I'm giving insulin, what's the potassium level? I'm giving more insulin, what's the potassium level? Let's see here, management of hypoglycemia. So give 15 grams of fast-acting concentrated carbohydrates. 3 or 4 glucose tabs will actually usually do the trick. 4 to 6 ounces of juice or regular soda, not diet soda. So again, these are quick fixes. Give her some glucose tabs, which will actually increase it. Giving your patients juice will increase it enough. I mean, I would rather have a patient who is hyperglycemic than hypoglycemic. So if I walk into my patient's room and let's say that they're sitting there watching TV, but the blood sugar is, let's say, 49, if the tray just showed up, I wouldn't be too worried about it because they're going to start eating. if their blood glucose is 49 and the tray just showed up, but they're actually having some nausea and vomiting, and they're not going to eat the tray, I might actually have to give them either glucose tabs or give them some sort of IV glucose in order to bring it back up because they're not going to consume it. Retest blood glucose within 15 minutes. Retreat that if it's less than 70. So even though you actually gave the glucose, you're going to recheck their blood sugar to make sure that what you did actually worked. If it didn't work, then you have to do it again. Let's see here, provide a snack with proteins and carbs unless the patient plans to eat a whole meal. So again, if the tray just showed up, I wouldn't be too worried about it. But if the tray isn't going to be coming for, let's say, another hour or so, then I probably would start giving them some, crackers and maybe some milk, maybe some peanut butter and crackers seems to do pretty well. Give them something. I'd rather them go from, 30 or 40 up to 250 and then try to fix that problem than not do anything and then just keep getting lower. Emergency measures, if a patient cannot swallow or are unconscious, obviously you're not going to give somebody who is not able to swallow, a mouthful of milk or something to actually get the blood sugar up. You're going to probably now look at either sub-Q or IM or IV glucose in order to bring them back up. You also could do dextrose IV, which is D550, and this will bring it up. But again, whatever interventions you do, you want to retest to make sure that they're actually working. And again, they're if it's an emergency and you give something, either they respond to it and become conscious and you know that it's working, recheck. Or if you do give it and they're not responding at all, then keep rechecking to keep redoing it. All right, so I know this was a very quick, fast-paced 30 minutes, but I know that it might be still pretty confusing, but lecture will straighten all this stuff out. Again, this is all you going back to block 2 stuff, going back to the type 1, the type 2 diabetes, and this is more than just them being a type 1 diabetic or type 2 diabetic and having high blood sugar. This is now they're sick and it's going to the extreme and they have to come to us to actually have it fixed. Again, we're really going back to basics, hydrating them, getting their blood sugar lower, and education. So if you have any questions, let me know, bring them to class, and we will make this all make sense.